Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Jen. How are you doing today?
Good. I was just thinking that's some pretty groovy music you have to start a podcast.
Nothing but the best here, right?
Great.
But what I asked you to come on tonight was I'd like to talk about wound management and all the different aspects that we can tackle pre-hospital. So if you wouldn't mind, it's been a hot minute since you were on. Would you mind just doing a real quick introduction of yourself?
Yeah, certainly. My name is Jennifer Gurney, and I'm an Army surgeon. I do general surgery, burn, and trauma, and I'm the chief of the joint trauma system. I'm so happy we're talking about wounds. It's one of the most important things, and I'm looking forward to the discussion.
So, just my experience in the field, wounds are always dirty. We spend all our time focusing on hemorrhage control and managing the airway, et cetera, and wounds are kind of like an afterthought. If I get around to covering it up, I'm doing pretty good. I feel good about myself. But like, I guess what should I be doing? Like, let's say we start extending this timeline out. Evac is not going to be for, hours, days. Like, how should I really be managing this stuff?
Yeah, it's a great question, and it's so applicable to the downrange environment. Wounds are, wound contamination is rarely immediately life-threatening. So everything that you just said, hemorrhage control, airway management, the TC3 algorithm to go through that. And then certainly if there's a minute of time left, and if we're in the prolonged care environment in the future, you really want to address the wound and wound management. And so the first thing would be is to clean it. Dilution is the solution to pollution, and it doesn't have to be anything super fancy. Water is fine. Soap and water is better. If you have access to any of the Hibiclens or any of those scrubs, just washing the wound is so important. I mean, I think that should not be underestimated. Is that more important than surgical debridement? Initially, I would say yes, no matter what the burn wound is, or no matter what the wound is, if a burn wound or contaminated soft tissue injury, just really scrubbing that wound, getting rid of any obvious contamination or obvious foreign bodies. People always say, should you go after fragments? Probably not initially. It's not, if anything that could be easily removed should be removed, and cleaning the wound is the most important thing. And then I'm just going to address this up front because there's this tendency to do this. And I've seen this in the deployed environment, even at the roll 2 and roll 3, there's a tendency to want to close a wound. And, because wounds do have a big burden, a physiologic burden, they are painful, they have inflammatory reaction, but closing a wound early is one of the most risky things you can do in the deployed environment. Even at the roll 3, we would wait to close wounds until they were clean. And we usually would keep them open until the casualty would move along the continuum of care and get to the next level of care. So keep the wound clean. I'd say that would be like the number one priority, is to keep the wound clean. And if you're holding on to a casualty, looking at the wound every day and then cleaning the wound. And tissue that's dead, like clearly dead, is not terribly hard to recognize and relatively easy to debride. So I think that in a prolonged care environment, people say, should we be doing surgical debridement? I mean, you shouldn't be debriding healthy tissue. Healthy tissue bleeds like crazy, but you should be debriding things that are clearly dead, and things that are dead don't bleed. So there's not really a risk of a big transfusion requirement if you're just debriding things that are obviously gray or black or nasty looking.
Okay. I mean, that absolutely makes sense. Now, the closing part, I guess, what's wrong with it? Like, I understand, like you're saying, don't do it, but what happens if I do?
Yeah. And that's a lesson learned and a lesson forgotten and a lesson relearned. And our casualties have paid a price for that. So closing a wound too early, before it's been evaluated, especially war wounds. I mean, war wounds are extremely contaminated. War wounds are analogous in the civilian world to like farm injuries and stuff. And those wounds, if you close them too early and there are nasty bacteria in the wound, you're just going to give them a great breeding ground. Leaving a wound open. Oh, sorry, the lights in my office go out. This is the government. That I have to move around. Okay, there they go. That'll only happen about 4 times during the podcast. But if you close a wound too early, the risk of infection and further tissue loss is real. And we see that even when patients would get back to the burn center. We would take them to the OR every day. And if you close a wound too early, the risk of infection, the risk of invasive fungal infection, all those go up. An open wound, now if it's a huge wound, it does have a catabolic consequence, right? If the wound is open for a long time. But a war wound, in my opinion, and I think in most people's opinion, should not even be considered to be closed for 72 hours. Shouldn't even cross your mind. So I'd say, if at 72 hours the wound looks beautiful, then you could consider it, but it won't. You keep it open for longer. There's science behind this too. There's this process called delayed primary closure, and that we used to do this when we did a lot of open appendectomies, or if wounds were dirty, like a animal bite wound. You'd clean the wound, you'd debride the wound, and then you'd put a dressing in it. I'm not saying that we should do this downrange, I'm just going to explain the science behind it. You put a dressing in it, and then you'd put loose stitches over it. And you wouldn't look at the wound for 5 days. Now, this is a wound that's been surgically debrided and is, or like an appendectomy where the appendix had perforated. And then in 5 days, so what happens in those 5 days, neutrophils migrate into the wound. Macrophages migrate into the wound. They start kind of eating all the nasty stuff. And then you start to get granulation tissue and fibroblasts. And in 5 days, you would take the dressing out, you'd look at the wound, and then you'd loosely approximate the stitches. That's called delayed primary closure. And I'm not advocating for that. I'm just trying to say the science behind leaving wounds open. Leaving wounds open is important so you don't block an infection in there, which would make things worse.
So, just any kind of wound management, you mentioned to start with cleaning, right? So just going over the CPG, they'd mentioned just boil some water. If it's clean enough to drink, it's clean enough to irrigate with. But
Absolutely.
some of these volumes, if it was clean, like somebody stuck themselves with a scalpel blade, 1 to 3 liters. And if it's a real dirty wound, there's going up to 9 liters. That's definitely cutting into some mission essential water. I guess, what am I looking for? Because I'm probably not really measuring any of it. I'm just squirting a bunch of water into it.
Yeah, that's a great question. And I think that that's something that needs to be considered in the prolonged care environment where, you can't carry the water with you. And like you said, going into the water might be mission water. You might not have the opportunity to boil it. You don't want to clean a wound with pond water. But tap water is probably okay. You're not trying to make the wound sterile. You're just trying to clean the wound enough so that there's decreased bioburden, decreased bacteria burden. So, soap, and it can be ivory soap. It can be soap and water is good for open wounds. If you have surgical soap like Hibiclens, like I mentioned, that's great. But the volumes, those volumes, there's also science behind that too. And that comes from orthopedic literature and general surgery literature that 6 or 9 liters really helps decrease the contamination. And this is when you're in the operating room, in a sterile environment, and you're really trying to get the wound ready to be closed or, but in the prolonged care environment where, so one, you're not going to close the wound in that environment. And if you're in a prolonged care environment for like 2 weeks, that's a really bad day. Our trauma system has failed, right? But we usually, and, we're thinking about this, 2-3 days, keeping the wound open, irrigating it with as much water as possible, and using soap, and then taking, cleaning the soap out of it. I think that's, And then the other thing is dressings. So what type of dressing to use? There's a little bit of science behind this. If you open a piece of gauze, like a 2x2 or 4x4, it has like, sorry about that. I got a phone call. So, if it has a matrix on, and that matrix, that lattice, as that wound goes, as the gauze goes from wet or moist to dry, it grabs all the grunge that's in the wound. It grabs the white cells, then that's that kind of stuff, that white, the pus in the wound. That's neutrophils and macrophages eating bacteria and doing their job, and it pulls it out. And then if that wound starts to bleed, a little bit of bleeding, that's really good, right? I mean, that means that that's a healthy wound bed. So there's art and there's science to wound care. And, the science from keeping it clean to using gauze to using wet to dry dressings, that's another thing to talk about, like what type of dressings to use. If you have, there are the dressings like the ABD pads or Telfa pads that aren't rough. Those aren't great for debriding wounds. Like, when you put a dressing in a wound and it goes from a moist dressing to a dry dressing and you pull it out and it pulls out the grunge with it, that's micro-debridement. You want that. And you pull out that and it's, then it starts to bleed a little bit. What you don't want to do is that dressing to just always stay moist. We do use moist dressings on things like if we have a healthy muscle bed, like after a fasciotomy, you don't want that muscle bed to dry out. So that's a different type of wound. That's a clean wound. It's a surgical wound. You don't want it to dry out. But a wound that has a risk for infection or contamination, keeping it clean, using a dressing that has, those lattices, so 2x2s, 4x4 Curlex rolls, opening it up, not just stuffing it in there, but opening it up, laying it on the wound. And then in the following day, hopefully that will be dry. You pull the dressing out. It pulls out stuff with it. You scrub the wound again. And the other thing, so what do you scrub a wound with? Well, I do it in the operating room. I use the surgical scrub brushes. But if you don't have that, you can also take a piece of gauze and, open it up so it's kind of rough and you can scrape the wound as well. That's micro-debridement. A healthy wound bed looks kind of beefy red. It looks beefy red. It bleeds a little bit. If there's muscle on it, that muscle would contract. If it's like soft tissue and fat, will get a nice layer of like pink granulation tissue on it. In a healthy person without a big bioburden in their wound, that'll happen as early as 48 hours, 48 to 72 hours. So that's kind of the art of wound care. And if you see enough wounds, and this is something else I would say to the medics out there, get into, general surgery clinics, the burn center, surgery rotations, and look at wounds, because that's the art of it, right? There's the science and the art. And the more you see, the more you keep cataloging in your brain of, well, that wound looks good, that wound doesn't look good. You start to get to know what a healthy wound looks like and what a wound that is not healthy, or sometimes wounds will stall in their healing process, and, what those types of wounds look like. So the other thing about a wound, I could talk about wounds all day. Because war wounds are a big deal. And, we made a lot of mistakes really along kind of the last 20 years with war wounds. But the other thing is you've got to look at them every day. You can't cover a wound up and not look at it, for a couple days later. The first time I started looking at war wounds was when I was a surgical resident at Walter Reed, and we were getting casualties back, from very early in the conflict. They would just be peppered in fragments. And let's talk about that for a second. Peppered in fragments, and we would just wash them out. And that's really not enough to just irrigate those. If there's fragment wounds all over, you've got to scrub those. And many times you actually have to open up the skin a little bit to be able to get into the wound, because fragments will leave like little cavities everywhere they go. So you want to, you do want to scrub those. Now, one of the challenges is if you're not in an operating room and, let's say the fragment injuries are along the leg and it injured a, vein or potentially an arterial branch, and you're scrubbing it out, and then there's all of a sudden a bunch of bleeding. Well, that's not great, right? So what do you do in that situation? Well, it wasn't bleeding when they arrived to you, so then you just pack the wound, right? You'd pack it with combat gauze. You'd want to do a thorough assessment of the extremity, what the vascular exam is, if there's good pulses, if you have a capability to do a arterial brachial index to be sure that there's not a vascular injury, and then get on the phone if you think there's a vascular injury and talk to somebody about how to manage that wound and really prioritize that evac. Because we're talking about wounds and we're just talking about the skin, subcutaneous tissue, and soft tissue, but underlying those wounds can be injuries to, arteries, veins, nerves. So those are also things to consider, because we do like the idea of aggressively debriding wounds, especially if you're just scrubbing them or using gauze. But, if the wound is overlying the femoral artery, well, you don't want to debride that, right? So you also have to be very aware of the anatomy and what vital structures are in close proximity to the wound.
Okay. And that makes absolute sense. Now you mentioned, having to look at the wound every day, probably cleaning it every day with at least soap and water. In the hospital, that makes absolute sense. I'm not in the hospital. I'm in the middle of nowhere. And whenever I open it up, it's now exposed again to just my daily living. So, is there a reason why, like you look at like different NGOs, the World Health
PRC.
Organization. Yeah. They tell you, hey, pack her up and leave it for like 3 days or 5 days.
Yeah. So that, like we talked about with delayed primary closure, that is a method. Okay. That's a method if the wound is not really contaminated. If there's a large amount of contamination in the wound, you are really putting that tissue and even that patient at risk. So if it's a relatively clean wound, even like an animal bite can be relatively clean, right? If you really can eat. Now, animal bites, they come with other risks because of the bacteria that are in a cat or dogs or, I don't know what else you get bit by, but in that environment, I suppose a horse, I don't know. You can get bit by
anything.
But like, so there's risks of that, those wounds require antibiotics too if it's an animal bite because of the different types of bacteria. But yeah, if it's a relatively clean, so let's say that it's not a combat war wound and it's like a machete slash or a knife, a stab wound or knife, then I think you could probably be less aggressive as long as that like knife isn't dirty. But war wounds from blast injury come with soft tissue destruction. And many times they bring bacteria from the ground into the wound. We've also seen things that ball bearings were feces contaminated. Not looking at those wounds really is a big risk. A low velocity wound or like a stab wound, yeah, you could probably wash it out. And if the tissue looks perfect, then wait 48 hours. But I just don't recommend that for worms. Exposing it to the environment is, as long as you're cleaning it, open wounds heal. Open wounds heal if you keep their bioburden low. If the patient has good nutrition, that's something else to think about. If you're holding a patient for a few days and they only have, soft tissue injuries, get them nutrition. Nutrition is important for wound healing. But I don't really worry about that exposure. Even, when I'm at the roll too, it's dusty and it's dirty. Our ORs aren't super sterile. It's why we don't do elective surgery like hernia repairs with mesh because our environment's dirty. It's probably not as dirty as, the Roll 1 environment, but, it certainly isn't sterile like a, hospital OR in the States. So I don't really worry about the risk of the environment. I worry about the risk of leaving a wound contaminated that's not appropriately irrigated and debrided.
Also, especially during, I don't know, maybe this second half of GWAT, this thing called Dakin solution started coming about from what I remember, it was from the fungal infections from these IEDs that were happening. And then like Dakin solution arrived, right? So, what is it? How do I use it? Give me the spiel.
Well, the first spiel has to start with history. It didn't come about during GWAT. Actually, Dr. Dakin's was either a chemist or a pharmacist in World War One. I'm going to have to look it up. Chemist or pharmacist, but not a surgeon. I think a pharmacist, maybe a chemist, but kind of during that time, maybe they were both. But anyway, Dakin solution is dilute bleach. That's all it is. And we've used Dakin's for years. I mean, I used to use it as a surgical resident. I still use it now. Dakin's has upsides and downsides. And you're right. It became very common when we were seeing a lot of dismounted complex blast injuries and the risk of invasive fungal infection, which is also kind of multifactorial. But when Dakin's was originally described by Dr. Dakin's during World War I, chemist or pharmacist, someone will have to text me, tell me. I'll look it up right after this. But it was described as an irrigation. It wasn't described as packing the wound. So you would irrigate. You would irrigate with Dakin's solution, and then you would do your regular wound care. How it's evolved and adapted is we use it as like a wet to dry. You know, we'll soak the gauze in it and put it in the wound. Man, it smells good, cleans up the wound pretty quickly. It makes the wound look beefy red. But here's the thing. It also kills your neutrophils and your fibroblasts and the good stuff in the wound. So for a wound that's like highly contaminated, for the first couple of days, Dakin's is good. But here's the other thing about Dakin's. After about 2 hours, it's just water. It's not bleach anymore. You know, it's just water. But the way Dakin's is made, it's essentially 0.25% Dakin's. So Dakin's is like half strength bleach. And so 0.25% Dakin's is cutting that in half again times 2. So it really does have to be dilute because it's sodium hypochlorite. And sodium hypochlorite is toxic to tissues. Right? If you like poured bleach on your skin, it would burn like hell. It's toxic to tissues. And so it is also toxic to bacteria. So Dakin's will clean up a wound, but it's not something that you want to continue to use after the wound has become clean because it really does impede with healing. I like using Dakin's in the operating room. They're actually making commercial now in lots of different formulas, but to wash the wound out. I like cleaning the wound with Dakin's. And then I'll irrigate it again and wash it out of the wound because it doesn't help with healing. So it's balance. And this is the other reason why it's good to look at the wound every day, right? I mean, once the wound is clean and the wound bed is healthy and has nice beefy red granulation tissue, you're probably not getting very far with Dakin. You're probably just hurting the fibroblasts and neutrophils and macrophages, and so then, you know, it's going to be slowing the healing process.
Okay. So you're definitely working against yourself with that. So definitely just try irrigating with it and then essentially washing that out.
Yeah, that's how we've kind of evolved to doing it, just back to the same way they did it in World War I, more as an irrigant. And, you know, there's all sorts of fancy things with wound care. You can use, VATS now, the negative pressure wound therapy, vacuum assisted closure devices. They even have ways you can instill Dakin's into the wound and then irrigate it out. You know, there's lots of ways to do wound care. I guess I'd say, in surgery and in life, when there's like 40 ways of doing something, it's probably because there's not one perfect way. And I think that's true, you know, for wound care. And this is where the art of wound care comes in. You've got to look at the wound and see what the wound is telling you. If the wound is gray and not bleeding and slimy, it needs debridement. If the wound is, beefy red and has granulation tissue, it's starting to heal. And I just think you have to, get to know the wounds that you're taking care of. I know that sounds really silly, but, if you look at a wound every day, you get to know, and you get to know how the patient heals. Patients have different healing trajectories. Some patients heal very quickly and others take a longer time. And that's multifactorial, with patients as well.
Yeah. Yeah. So, I guess just getting into debridements. So I'm looking at a wound. It is just mangled tissue. There's some that is obviously dead. Some I don't know. And, some I'm kind of afraid to even get into. So would you suggest maybe early just cutting the blatantly obvious dead stuff that will not come back?
Yeah. And in the prolonged care environment, to put that burden on a medic is pretty tough. But this is where I also think getting into hospitals and getting into the OR and seeing how wounds are managed, war wounds, especially big blast injuries or mangled extremity, debriding the dead tissue, something that's gray or clearly dead. And you can do that with scissors. I use scissors over a knife, like, Mayo scissors or surgical scissors. But don't debride anything that is still alive. You really want to keep, especially in like an amputated extremity, you really want to keep live tissue alive the best you can and debride what's dead. It is important to debride the dead tissue because it's a great place for bacteria to live and for infection to spread. The way that we had the, luxury, I should say, of doing it during GWAT, even if you had 4 or 5 patients to take care of a day, that's 4 or 5, OR cases as opposed to 50 OR cases, right? So we did have the luxury of taking these casualties back to the OR, almost every day to look at the wounds. That allows you to not do massive debridements. It allows you to just examine the wound and only debride the necrotic tissue and keep what's viable. A lot of my deployments were with orthopedic surgeons who were, very keen on saving as much tissue as possible for reconstruction options, but you don't want to like these mood lighting. Okay. But you don't want to, you don't want to over debride if you don't have to, but you certainly don't want to put the casualties' life at risk by leaving dead tissue and then putting them on a helicopter ride or putting them into a situation where no one can look at their wounds for 48 hours. Then in that case, I think you have to be a little bit more aggressive. Like if your trauma system, like if you're taking care of someone, you debride what's dead and you're going to put them on a train or on ground evac and no one's going to see that wound for 48 hours, well, then you should probably be a little bit more aggressive with your debridement. You don't want to take off live tissue. Let me just say this. If someone has like a mangled extremity, they stepped on a explosive IED or whatever, very old school is to do a guillotine amputation, where you have a tourniquet on, you just cut below the tourniquet. That is almost a never event these days. There is one situation that we still do that, and that is for like a necrotizing associated soft tissue infection. So a true case of gas gangrene where you're literally watching that tissue die. And we don't even do it for those anymore. Those we take to the OR and we're debriding, doing a lot of sharp debridement. I have not done a guillotine amputation since I was a resident. And, so that's, I think sometimes I've gotten that question on the advisor line calls, now, I guess in the future operating environment, God forbid we start seeing a lot of, tourniquets, high and tight tourniquets or above knee tourniquets, and the extremity is completely dead beyond it because the tourniquet wasn't converted, which would be really bad. And we know we're seeing that in Ukraine, and we're seeing, tourniquets used for wounds that don't need it, and then the extremity distal to the tourniquet completely dies. Well, then in that case, you'd probably have to do a guillotine amputation. And that just shouldn't be happening. We have to train people to assess wounds. So let's now take a step back. We're talking about wound debridement, but let's take a step back on like who needs a tourniquet, because a tourniquet and a prolonged tourniquet is going to cause all your wounds to be ischemic, right? And so in order for a wound to heal, it needs blood flow. And so a prolonged tourniquet on a wound is going to absolutely increase the amount of non-viable necrotic tissue in the wound bed. So I think that we need to be preventing that as much as possible with teaching, early wound assessment and tourniquet conversion. We hear story after story after story about someone having blood on their uniform, and I think it's because the tactical environment is so challenging in Ukraine. They throw a tourniquet on and nobody reassesses it, and there's no wound. They just had blood on their uniform. And, these are really preventable limb loss and sometimes life loss if they have renal failure, compartment syndrome, like everything else. So I think that's the other thing is we've got to be training tourniquet reassessment, and conversion when we can. Otherwise, we're going to be dealing with a lot more ischemia and wounds that are ischemic. And wounds that are ischemic are going to have more non-viable tissue, need more debridement, and take longer to heal.
Yeah, and I think a lot of that has to do with one, like how they're trained for speed overrides the assessment. Does this bleed actually require it? If that makes sense. It's bleeding, throw a tourniquet on it, we'll deal with it later, but later never comes. You know?
Right.
Because it's not always easy to just say, that's an arterial bleed, that's a venous bleed. It's really easy in that kind of educational environment. It's not nearly so easy when you're ducking rounds.
Yeah, no, I mean, I 100% agree. The tactical environment kind of dictates that, expedient tourniquet placement because of the concern for hemorrhage control. But, I've been thinking about the kind of tourniquet problem a lot. And I think you mentioned education. I think we've got to, differentiate training and education. We can train anyone to put on a tourniquet, which is good. But are they educated and do they understand the consequences of ischemia? And, right, exactly. And so that's what we haven't educated. We've trained, which is great, but we haven't educated. Yes, tourniquets are life-saving, but, an inappropriate tourniquet can threaten the limb and even the life. So we haven't educated on the risk of ischemia. And, this also, you can go back to history. I mean, everything, it's like we repeat ourselves. We did have tourniquets during World War II. And they were massively overused, similar to what's happening in Ukraine. And because of that, and they didn't have dialysis then, they didn't have all the things to keep a casualty alive after a massive ischemic burden from an unnecessary tourniquet use. So tourniquets were then forbidden. And in Vietnam, there were no tourniquets. And casualties died of, survivable extremity injuries. And so thank God we have tourniquets back. They've saved thousands of lives. But we've trained and everybody knows how to use one. We haven't educated on the risk of ischemia.
Yeah, absolutely. And I think I found if you teach both the good and the bad about whatever intervention you have, then that sticks a little bit longer than the cheap trick of like, all you got to do is, I tell my students, if anybody ever tells you all you have to do is, look at them suspiciously.
Right. I'll say that in my next line. Well, all you ever have to do. No, you're totally right. Yeah, for sure. Agree with you.
So let's say in our make-believe patient, we did have a tourniquet on. It's just a mess. It's a mess. I at least try to convert the tourniquet and I can stop major bleeding with pressure. With a pressure dressing, little capillary bleeds kind of around it. Should I just leave the tourniquet on?
No.
Or?
You should not. You should try and get the tourniquet off. So we talk about, wounds have a spectrum, Dennis, just like anything else, like a spectrum of, bad wounds, but not really life-threatening to we've seen them and if you haven't seen them, you've seen pictures of them, just wounds that are just the thigh is blown up and the thigh is 3 times the size as normal because it's, muscle is, expanded and So those wounds in the prolonged care environment are tough to deal with. Those wounds are tough to deal with even in the operating room. It's usually, you get help in the operating room, somebody else to hold up the leg as you wash it out. You're getting hemorrhage control and debriding the wound at the same time. You need a transfusion capability. Do not try and, debride a massive soft tissue wound without a transfusion capability. So those wounds would be tough. You really would want to try and convert the tourniquet. And then it's a balance. If you do a lot of debriding, it's going to bleed. And if you don't have a transfusion capability, then you're putting that casualty at risk of, hemorrhage as well. So it's really just the balance. I hope that we don't have medics in those scenarios, but we will. And I think that those are also times that hopefully we'll have capability for telehealth support so someone else can see the wound and kind of somebody who's seen a lot of really bad wounds and can say, yeah, you probably need 3 units of blood if you're going to, undertake a debridement of that, extremity wound or soft tissue injury. So, I mean, it's the spectrum of injury, just like, anything else. I think that has to be considered.
How soon, let's say we're able to get a tourniquet converted, we have a pressure dressing like hemorrhage. It's not in my forefront anymore, right? We're getting the patient slightly, somewhat resuscitated. Like, he's not going to die. I don't think he's going to die, period, as long as everything stays stable. When should I start thinking about wound irrigation? Like, if I think I'm going to convert this tourniquet and I have time, could I start the irrigation before I start packing?
Yeah, that's a great question. That's also kind of an art science of wound care or wound management as well. So you converted your tourniquet, and it's a moderate to large wound. You have your wound pack with combat gauze or regular gauze, and now you have 8 hours till transport. If the patient is doing well and if you have blood, I would say, 4 hours later, if the patient's is resuscitated and hasn't, bled out and is coagulopathic, like if they have somewhat normal, like, lab values, not that you can check that, but if they're not like coagulopathic, then I would take the dressing out a few hours later, 2 to 4 hours later, and you'll know right away how much it's going to bleed. And then at that point, I wouldn't like scrub like crazy because it will bleed, but I would wash it out. Wash it out with as much water as you can. You want the water to be warm, by the way. You don't want it to be cold. And then repack it. If tissue is obviously, now, if you see like a little bit of dead tissue around like the skin edges or whatever, that's fine. A little bit of dead tissue, that's fine. But if there's a large number or a lot of like necrotic or clearly non-viable like black tissue, you'd want to debride that as well. Carefully, because as soon as you get into healthy tissue, it's going to bleed, which is a good thing. But if you don't have a transfusion capability, that's not a good thing. First do no harm.
Yep. Now, with that bleeding, would you just do a pressure dressing or just at least direct pressure to try and slow that down or stop it?
Yeah, absolutely. Direct pressure, repack with combat gauze or some type of gauze. Do everything you can to avoid placing another tourniquet. It's always an option, right? If someone's you don't want them to bleed to death, but if you place another tourniquet, you're giving that tissue a second ischemic hit. And that is going to, every time tissue gets ischemic, it's going to have a harder time healing.
All right. That absolutely makes sense. So we irrigate it out and probably redress it and maybe revisit this again tomorrow. Yeah. Okay. Some other things, I guess, a little more austere wilderness medicine-y, is honey dressings. And I've even seen this in the hospital, so I guess it's not really wilderness medicine, but...
I love honey. I love it. I love using honey. I mean, the nurses hate it, and I worked in the burn center for many years. And nobody really used honey. Actually, I didn't use honey at all in the burn center. And I would watch when you get a bad burn patient, you get them initially resuscitated, and you bring them up to the burn center, you take them to the shower. And they scrub the wounds, they wash them out, and then they'd put dressings on them. And the most common dressing that they would use at that time was sulfamylon. And the wounds would do very poorly after that. They'd turn white, they'd turn dry, they wouldn't heal, they'd need skin grafts. And I did a lot of reading, and I won't go into all the science behind it and why we use sulfamylon in our burn center, but it really was for Pseudomonas control, but it was kind of before we started using early excision. And anyway, I just did a lot of reading on it. And I remember, I go way back to when I was a junior surgeon, where I was Major Gurney, and I was working in El Paso, and I guess as the junior guy, I had to run a wound clinic, and I learned so much about wounds. There was this really old Argentinian surgeon, civilian surgeon who worked there, and we would manage these, bad diabetes wounds and surgical wounds and lots of wounds. And he said to me once, he said, if you ever have a wound that can't heal, just put a little bit of honey on it. And I just remember thinking, that's freaking crazy, whatever. But he was right. And it's not wilderness medicine. It goes back to over a millennia ago, people have been using honey. The Egyptians used honey. Let me tell you something. Nothing grows in honey. Period. Nothing grows in honey. Botulinum spores survive in honey. Spores survive in honey. That's why you can't give honey to a newborn, because then the spores can germinate and they can get botulism. But nothing grows in honey. Honey is an incredible wound adjunct. I started using it a ton in the burn center. The nurses hated me for it because it really is a pain in the ass to use. I mean, it's sticky, it's messy. It's once it kind of is on, if it's on tissue, in the burn center, everything's hot, so it melts, it gets everywhere. But man, it works. It is great. I think that now we use medical grade honey and we use Manuka honey. Medical grade honey is just irradiated because it kills the botulism spores if they're in there. It's nothing special. It's just irradiated. So, the problem is with a lot of commercial honey is it's not real honey. It's like corn syrup and some honey, and it's like cut with stuff. I don't know. But real honey is good for wounds. Nothing grows in honey. And so I'm a huge advocate for putting honey on wounds. What's interesting, I've used honey hundreds and hundreds of times on wounds, and I've never regretted it, except the nurses don't like it. But they use it more now because they've seen a big difference. It makes a big difference in wounds. The way I use honey, and you can use it in lots of different ways, is I use it with Xeroform or Vaseline dressing because otherwise it slides all over the place. But you could put honey in the wound and put gauze over it. I've used honey on X-Fix sites that have gotten infected when I've been at the Roll 2, when we were managing some host nationals and they were getting bone infections. You can use it on the skin. You can use it on the soft tissue. Two things are interesting about honey that people should know is one, it hurts. It burns because I don't know why. I think it's because it pulls fluid out of the wound, but especially on burn wounds, it actually stings a lot.
Yeah, it creates hydrogen peroxide from the water.
Yeah, so there's that, and it has to. So the hydrogen peroxide is one of the reasons that they think it works. What's interesting is hydrogen peroxide is not great for wounds, but honey helps wounds heal as well. So, but it does something to superoxide dimutase and does something to neutrophil burst. So yeah, it does. It creates hydrogen peroxide, and it also dries wounds out. So our nurses in the burn center, they started using either bacitracin or petroleum with it, so it would not dry the wounds out as much. But honey is a great adjunct, and I don't think it's just for wilderness medicine. I mean, I use honey at the U.S. military's world-class and only burn center. I choose honey because I think it is a better wound adjunct than anything else that we have. And I even use honey under vac dressings. I call it a sweet vac. But it works. It is really good for wounds. I mean, sometimes we get really, really fancy. We don't have to. The basics are good. And so if you're in that environment, would local honey work? If it's real honey, probably. Now, is there a risk of getting botulism in anaerobic wounds or wounds that don't have enough oxygen? There probably is that risk. I've never seen it documented, but there probably is that risk, which this just goes to, you want to keep the wound, you don't want to close it so it's not anaerobic. You want to look at it every day, and you want to debride what's dead. And but huge fan of honey.
So the botulism in the honey, you put the honey in the wound, wouldn't the honey keep it kind of dormant?
I think so. I mean, like I said, I've never seen anything documented on it, but I mean, if the spores have a chance to, if the honey, let's say, has had a fair number of botulism spores in it, theoretically, just like they can germinate in a newborn stomach because the newborn stomach doesn't have acid, theoretically, it could do that. I've never seen that documented. I've never seen it. And I've looked up a lot of stuff about honey. The thing is about when you look at the data on honey, is it usually comes from low to middle income countries because they're not using, all the expensive wound adjuncts. And what they document also, not just the decreased bioburden, but they document the wounds heal faster. So, I mean, I think I personally think it's a best practice, just like looking at the wound every day and irrigating and, debriding it. I think it's a best practice, and I think we should be using it more. Now, is my opinion. Not everybody agrees with me, but I think the people that have used honey, they recognize the value that it has. It's just such a pain to use.
When it comes to just wound management in general, as a surgeon, having to receive the messed up medicine that I did in the field, what do you wish that we were doing more often?
I think you guys do a pretty good job. But I haven't received any patients from you, Dennis. So, maybe
you don't want to.
the Iraqis and Afghans used to always close wounds early, and we would just reopen them. They would send us their patients, and they'd have their wounds whip stitch closed with a silk suture. And I think that that's probably not a good idea. We would always reopen them. So, I think that, well, to be fair, in our trauma system over the last 20 years, you guys didn't really do much wound management. It was hemorrhage control, airway, and you'd move them to us, and we did the wound management. So I don't really have anything to say, but I know that from when I was at the Roll 3, you'd receive from Roll 2, and I was at Launch Tool for many years. And, I think inadequate debridement, over debridement. So that's kind of that art, right? But inadequate debridement is more common. Closing a wound too early. I guess a question would be, do you start antibiotics? So there are certain, wounds, if they're highly contaminated, yes. But the most important thing you can do for a wound is to clean it, right? It's so debridement and clean it. One of the reasons, and we don't really have true data that really supports this, but, one of the reasons that we might have seen some fungal infections, it's, yes, definitely the blast, the tissue description, the fungus in the dirt. But if we overuse antibiotics or, using too many of them, we're selecting for those. So that could have been a risk. I have a huge interest in wounds. I did run the ISR's, Institute of Surgical Research, wound research team for a little while. One of the things I kept trying to get, and now I'm going down a total rabbit hole on some research stuff, but, going back to Dakin's in World War I and Fleming, who developed penicillin, which has saved so many lives. Antibiotics have saved so many lives. But we know we overuse them. We also know that bacteria are in competition with each other. They're in competitions for nutrients, like that they get from the wound and they get from the tissue. So one of the studies I've never seen done, so if there's any researcher with a lot of money out there, do this study. But we have spent over a century trying to kill bacteria. Over a century. Antibiotics, more antibiotics, debridement, more antibiotics, debridement. And we have learned so much in the last, 8 to 10 years about the microbiome. And, there are some bacteria. I always use Corynebacterium as an example. I do have a degree in microbiology, so I'm not like a total, just like wound nerd. It's an interest of mine. But there's some bacteria that are really very benign in a wound. And what I'd like to see in the future is medics with little syringes with 5 billion benign bacteria, like Corynebacterium or maybe Lactobacillus or something like that. And then they mix it with something into a slurry and they pour it in the wound. Now, I'm not saying to do this. There's no studies that have been done on this. But I really think that this is a potential opportunity for research. And I bring it up to people who have money to do research and all they want to do is look at plasmids and new antibiotics and more plasmids and, crazy things. Right. That's where the money is. But you can, and this thing would be cheap, right? There's no money in this, and then you put that benign bacteria in a wound. Let it fight the bad bacteria. These are hardy little bacteria, things like Corynebacterium. They will fight the bad bacteria. And then you have a wound that is colonized with a okay bacteria, and then you get to a higher level of care and you wash it out. And I just think that we just like everything in medicine and science and surgery, we always know more. We think we know more than what's actually to be known. Like, we have so much to learn. And I think that capitalizing on, more benign bacteria, inoculating really, really dirty wounds with those, let the bacteria fight it out. Then you're just killing the bacteria that's easy to kill. And then you have a healthy wound bed. Nobody's done it. I don't suggest anybody do it. I just hope that there's some research that, really looks at novel ways that don't involve bigger and bigger antibiotics, because we know antibiotic resistance is a big problem in wounds. Novel ways and things we can give medics, easy tools to kind of manage the bioburden and bacteria burden of these wounds.
If only the government had an institute that did research.
I spent years at that institute. I always bring this up, and I'm telling you, they're just not interested. Someday they will be, and someday somebody's going to do that, and they're going to be, they'll be famous. Yeah. And I'm going to refer them to this podcast and say we talked about it.
Awesome. Well, I really appreciate you taking the time and trying to explain this to me.
Yeah, well, I appreciate your interest. I think that, I think we have a lot to learn with wounds, but I think the main principles of keeping a wound clean, trying to, if you're concerned about a wound, looking at it every day, irrigation and debridement, communication along the continuum of care, be aware of the anatomy and what other structures are in proximity of the wound. And if it's dead, it's okay to debride, and use more honey. I guess those would be my little lessons.
Awesome. Well, thank you.
Yeah, thanks, Dennis. Appreciate it.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.